from SpineTV, OrthoTV, and Vertebral View Show. Today we have a very interesting topic, things you should know about intraoperative neuromonitoring. And we have like star-studded cast who will be discussing this important topic. We have Dr. Taarini Johri, last year's BOS Rising Star Award winner. She will be talking on basics of IONM, anatomy, physiology, indications, and contraindications. She just finished her RC fellowship. She's started with the knowledge and she will share her knowledge with us on Diwali. Then we have Ms. Parichar Jasawala, one of the most respected and senior most surgical neurophysiologists, and she will talk on the critical role of IONM in spinal surgery. Followed by we have Ms. Nikita Singh, one of the brilliant minds. She will be discussing understanding and avoiding IONM errors. Then we have our own Dr. Siddharth Shah, UK returned spine surgeon. He will discuss communication and workflow with the IONM team. Followed by the most enthusiastic spine surgeon from Bangladesh, Dr. O Z M Dastagir. He is very much academically oriented and always wanted to discuss and share his knowledge with us. And we will discuss current concepts, IONM checklist, the most important one, and the literature review at the end of the discussion. With this, without taking much time, we will start the discussion. I request Dr. Taarini Johri to discuss a topic. Thank you. And I'll stop sharing.
Thank you, Dr. Raj. I'll just share my screen. All right, so hoping my PowerPoint is visible.
Yep.
Okay. So I would like to thank SpineTV and Dr. Raj for this opportunity. I feel as spine surgeons, we know what IONM is, but we do not understand it so well. So let's do that today. Before we begin, let's do a quick dive into history. So this is the era where there was advent of Harrington rod, instrumentation for scoliotic deformity correction. Everybody was like, yay! So we were subjecting a curved spine to distraction forces, right? Then a while later, there was an SRS report which said that a few patients who underwent this surgery would wake up with irreversible dense neurological deficits. So then everybody was like, no, what happened? So we knew we did not know how and when was this happening. And that is why we started thinking that we needed an early warning system. We knew it was because of the surgery, but how? So to monitor for neurological examination, right? We wanted something that we could do intraoperatively. That's when the Stagnara wake-up test came into being. Back then, it was very famous. The anesthetist would reverse the effects of anesthesia, and the patient was asked to move their feet. Now, there were major limitations to this. You needed the patient to cooperate. First, counseling them that this was going to happen was a big deal. Second, it was not a continuous monitoring and nor was it real time, right? So it was only when the surgeon asked for the test. And lastly, it could not be performed repetitively. That is when people started exploring the intraoperative recording of electrical potential produced by the nervous system, trying to look at the neurology indirectly, right? So we developed the SSEPs and the MEPs, that is a somatosensory evoked potentials and the motor evoked potentials. Even then, there were cases where patients with normal SSEP would wake up with neurodeficits. And so we understood that this modality, a single method cannot cover it all. And so now we have the multimodal IONM. With this background of history, we now understand IONM and what is it. It helps in monitoring the integrity of your sensory and motor pathways by continuously monitoring and localizing the vital neural pathways, right? This helps us prevent post-operative neurological deficit by an early intervention. First, so to understand the neuroanatomy, we must know that the spinal cord, we are testing particular tracts, and these are present in particular locations in the spinal cord when you look at a cross section. Posteriorly is dominated by the dorsal columns that are responsible for all our sensory functions. Anteriorly, we have the corticospinal tracts, or also known as the pyramidal tracts, which are responsible for motor functions. And the electromyography is used as it targets the peripheral nerves. A peripheral nerve is nothing but when the ventral and dorsal root come together and form a spinal nerve. Now, this is very important because this is what we base the IONMs on. There's a motor pathway and a sensory pathway, and each path is fixed. It's like, where do you catch the mouse? You know, it's gonna enter at a particular place and exit at a particular place. So for motor, it's always the brain telling the body, sending the signal down the spinal cord and telling the body to do a particular action. And for sensory pathways, it is the body that is collecting a stimulus from the environment, sending it up to the brain to process it, and that is how we understand sensations. Blood supply is important because when we are doing certain spinal maneuvers, you put a lot of stress and traction on the spinal cord, which could also lead to ischemic spinal injuries, which is a very important component. So the aorta gives off the posterior intercostal artery, which then would give a segmental artery. Now, this segmental artery has a spinal branch which goes intradural and gives two radicular arteries. Everything is fine. One radicular goes anterior, gives the anterior spinal artery supply, and the other gives posterior two spinal artery goes supply. But the thing changes when it's at T8 to T12, where you have something known as the dreaded artery of Adam Pewick's, which is the sole supply of the anterior spinal cord. And we know that the anterior spinal blood supply is supplying the 2/3 of the anterior spinal cord. Now, with the combination of knowledge of the injury patterns with the presence, location of the tract and the blood supply, we know we can kind of point out what's going wrong intraoperatively by stimulating these particular tracts. So coming to modalities, in monitoring, we have the SSEP, MEP, and the EMGs. Each test is chosen depending on the location of the surgery and a patient's pre-existing injury and deficits. And each patient is their own baseline or control. Now, understanding abnormal is more important than normal for IONM, especially in myelopathic patients. So if you imagine there's a switch, you turn on the switch, the signal is going through a wire and the light switches on. Similarly, evoked potentials are nothing but when you produce a stimulus, it goes through a neural conduction and there is an evoked response known as the amplitude or the latency, which we are reading. Amplitude is the intensity of the electrical current that we, or the evoked response that we record. Latency is the time from the stimulus to the evoked response, and morphology is self-explanatory. It's the shape of your graph. SSEPs we already understand is going to assess the entire sensory pathway. It reflects the posterior column integrity. And also if there's any stretch or ischemia, there will be an altered signal. Here, the other speakers obviously will be talking more in detail, but as you know that SSEP begins in the periphery. So at the bottom right, see the nerves that are commonly the nerves that you'd commonly put the electrodes along. For the upper limbs are the median nerve, and for the lower limb it is the posterior tibial. The stimulus is given and it travels up to the cranial portion of your head at C3 and C4, which is kind of relating with your somatosensory cortex of your brain. And that is where the signals are recorded. The neurophysiologist would look at the latency. That is, when you give the stimulus, how much time does it take for it to reach those intracranial electrodes, the somatosensory area? For median nerve, it's around 20 milliseconds, and for posterior tibial, it is around 30 to 49 milliseconds. Any difference or any alteration in this is would be abnormal, and they would alert the surgeon. Now, the responses are averaged around 500 to 1,000 times more to extract away those SSAP signals from the background electrical activity of the brain. And that is why, although it is a continuous monitoring, when the surgeon asks for it, there is a little delay to get the results. MEP is a motor, it reflects the motor pathway, also the perfusion and ischemia. We stimulate the motor cortex transcranially, that impulses travel down to the spinal cord, then to the nerve, and finally to the muscle, where we record the response. So here the electrodes are placed at C3, C4 again, but a little anterior to the SSEPs. These are the muscles and the roots, right? That these electrodes are placed in specific muscle bellies that you want to read, which will again be covered in detail in the next talks. So the waves that these produce are the D waves, I waves, and myogenic MEPs. The direct waves, the advantage is that they're generated proximal to the anterior horn cells and the neuromuscular junction. So they're not affected by anesthetic agents, but it is very invasive and it is now mostly only used for intramedullary spinal cord surgeries. What we are going to focus on is a myogenic MEP, which is a submitted potentials recorded from the corresponding muscles via motor cortex stimulation. What does that mean? This is what it is. So initially when MEPs were made, there was a of single pulse stimulator, where a single pulse was sent down the transcranially, and there was an epidural recording where you could see direct and indirect waves. This is the direct D waves, right? And then you could read the MEPs, but this was an non-anesthetized patient. When this was tried under anesthesia, we could only read the one direct wave, and there were no readings for the muscle MEPs. So that is when Taniguchi et al. Reported that this anesthesia-related signal suppression could be overcome by using short stimulation pulse streams. That is, instead of a single impulse, now transcranially you're giving around 5 to 7 electrical pulses, and it helps these motor neurons to reach a threshold, firing threshold, and generates MEPs. So this is the concept of the transcranial myogenic MEP we use now. Triggered EMGs are nothing but they are the basis for medical monitoring, or also to know if a peripheral nerve is affected or not. Now, how does this work? There's a probe, like you can see on the top right corner of the screen. There's a ball-tip probe that a surgeon inserts into a screw tract that has been made. If it is a good screw tract and there is no breach, there will be no reading. But even if there's a little bit of a median breach, there you will get an EMG response. So there have been thresholds set that if the response is more than this much, then the neurophysiologist will alert the surgeon and say, no, you have to replace the screw or reposition it. So it is very useful when you're doing complex deformities because of the altered morphology. And also very important to have a good myotomal knowledge, because you need to know what route the surgeon wants to check for which muscle. Now, indications for IONM are so many, but spine-related, definitely scoliosis correction, lumbar interbody fusion surgery, especially XLIF, where we want to look at the lumbar plexus of the genitofemoral nerve. Then there is minimally invasive surgeries where through the Jamshidi needle we can actually find out we can do the monitoring. Then there is a spinal cord tumor like intramedullary. Some even use it for intradural. And cervical spine surgeries, which is very important, especially during positioning, because you want to know, like you take a signal before positioning and after positioning, which probably is going to get covered in the next talk. And there is a literature review talk as well, so I'm not going to say anything on that. Now, EMG, like I said, is very important for pedicle screw placement, as well as, for example, if you're doing a cervical spine surgery and you want to know if you had a C5 policy at that moment or not. Contraindications from the references that I looked into, there was no absolute contraindication. We can probably have a discussion on that, but there were relative contraindications that were based on if your electrical impulse is going to affect the device inside the patient, or that device or whatever is inside is affecting your results. So like, for example, implanted vascular clips or pacemakers, or, if there's a difficulty in putting the electrodes because of skull defects. So the take-home current today would be better the devil you know than the devil you don't. Knowing versus understanding IONM makes a big difference, because when you understand the anatomy and physiology, I feel as a surgeon, you can apply it much better into your practice. These are my references. Thank you.
That's a wonderful talk, Dr. Johri. And it gave a great information about anatomy, how to see things real time. And with that, I request Ms. Parichar ma'am to share her slides, and we'll discuss further about her talk.
Yes, Dr. Raj, good afternoon,
Yes.
everyone, and thank you for giving this opportunity. Can you all see my slides? I've shared my slides.
Yes,
okay.
You can see. Yeah.
Okay, fine. Today I'm going to talk about intraoperative neuromonitoring in spinal surgery. Okay. IONM provides real-time function assessment of of neural structures, allowing immediate detection and prevention of potential defects. The commonly used modalities include SSEPs, transcranial MEPs, D-wave, and EMG and triggered EMG. The goal of having the IONM, the goal is to preserve the neurological function and to improve the post-operative outcomes. Okay, next slide. Objectives of IONM is to detect the impending spinal cord nerve injury at an early stage, to guide the intraoperative decisions to prevent irreversible damage. If I tell the surgeon at a very early stage, then it is surgeon is able to reverse the steps. It improves long-term neurological outcomes. It provides documentation of neural integrity throughout the surgery. And it serves as a communication bridge between the anesthetist, the neurologist, and the surgeon. The purpose of neuromonitoring, it is to prevent intraoperative spinal injury to the spinal cord and the nerve roots. It provides real-time feedback about the neurological function, and it allows immediate corrective action, like during position, if we have after position, if we have signals have dropped compared to what we have taken it in supine, then we have to reposition the patient. Sometimes when the patient is on traction, then even while giving traction, we have to keep checking. When they keep giving it to increase the weight of the traction also, at every time we check at 2 kgs, at 4 kgs. If there is any signals fall, then we immediately inform the surgeon and the steps have to be reversed. Same way while positioning the screws also, after every screw is placed or anything, instrumentation is done, we take a reading. If there is any drop in the reading or anything, then the surgeon has to be informed and the steps have to be retraced. Then the common spine surgeries where IONM is used. That is complex spine deformity surgery, scoliosis and kyphosis, then spinal tumors, intradural tumors, extradural tumors, and extramedullary tumors. Then in revision spine surgery, where increased risk of neural injury is there and high-risk procedures. Degenerative spine surgery, so like cervical and lumbar spine procedures. And in trauma surgeries where spinal cord injury or vertebral fractures. That is the time when we have been called, and even in detethering, it is useful. Then the modalities which are used in the surgeries. SSEPs, first thing is SSEPs. It monitors the posterior and the dorsal column, that is the sensory pathway, and it is to be used in all spine surgeries. Then MEPs, that is the corticospinal tracts of the motor. It is used in deformity correction and in tumor removal surgeries. Then free run EMG, that is to see the nerve root irritation. It goes on spontaneously. There is no current required in that. And it is used in tumor removals and in detethering of the spinal cord. Then triggered EMG, that is to monitors the nerve screw proximity and the procedures, that is pedicle screw testing, used in pedicle screw testing and nerve root identification, and even detethering also to identify the nerve roots and before cutting the phylum. Then the D wave, that is the direct corticospinal response, and it is very useful in intramedullary spinal tumors. The alarm criteria, when do we inform the surgeon? When the SSEP amplitude decreases by 50% and there is a 10% increase in latency, the initial latency, then we have to inform the surgeon. At the same time, we also monitor the MEP. So if the MEP amplitude also, if it is dropped by 80%, especially if it is only low, like one side or anything, if it is general, then we have to see whether there is anything relating to anesthesia or anything. But if it is something focal and one particular side, then we immediately inform the surgeon if there is a drop in amplitude of the MEPs or totally absent, also suddenly one side has gone. Then for EMG, if you get a persistent neurotonic discharges, then we have to tell them whether there is any traction or anything retractor which is pressing upon the nerve root or anything, then we have to inform them. Then in D wave, if we are doing a D wave, then if there is a 50% amplitude, actually 30 to 50%, we immediately inform. Then the position has to be seen, for between 30 to 50% amplitude. Then first we have to recheck the electrodes also, the anesthetic depth, the hemodynamics, the surgical step, everything. If there is no improvement, then you have to alert the surgeon. Before informing the surgeon, I think as a neurophysiologist, we always first check our side properly regarding the machine, whether the current given is proper, everything, and then alarm the surgeon. The role of anesthesia. If we are doing neuromonitoring, I think the most important person for us is anesthetist. You have to have cooperation from the anesthetist because the anesthesia required is different. Require total TIVA, intravenous anesthesia with propofol and a short-acting opioids like remifentanil or fentanyl is preferred. Volatile anesthetics and neuromuscular blockers suppress the MEPs. So we have to tell the anesthetist, do not give a muscular blocker as it suppresses our MEPs. The mean arterial pressure has to be above 80 to ensure cord perfusion. If the pressure drops, then if your signals have dropped generally, so then you have to keep an eye on the pressure and see. If the pressures have dropped, then request the anesthetist to maintain the mean arterial pressure. Another thing important for IONM is like to have the signals properly. Hypothermia, hypotension, anemia, electro imbalance, and all other things also alter our evoke potentials. So anesthetist wise, we need real cooperation. And if the signals drop, we have to first see the anesthesia side also before informing the surgeon. Then troubleshooting. First, check your electrodes, connections, everything. Verify that the stimulation intensity and the montage used is proper. Talk to the anesthetist, reevaluate the anesthetic agents, ask whether they have given any neuromuscular blockers or any propofol bolus or anything which would affect the signals. Even the propofol bolus does affect the signals. So if there is a generalized loss in signals, then evaluate all these things before informing the surgeon. Even the physiological parameters, map, temperature, SpO2, everything has to be checked and then communicate changes with the surgical and the anesthesia team. What are the golden rules for the surgeons? When you are using the probe to check the pedicle screws or to check so do not stimulate through the dura because dura is not conductive. It won't give you a reliable triggered EMG response. Even during the phylum connection, phylum checking the phylum and all, do not stimulate the dura. Avoid stimulating over the bone or instruments because bone and metallic retractors disperse the current. Always check for wet field before stimulation. If fluids like CSF, blood, irrigation pools around the stimulation site, then the current gets shunted. Keep the stimulation probe sharp, clean, and monopolar. Dull probes give poor stimulation, and the bipolar probe is not suitable for deep root mapping. Avoid retractors pressing on the nerve roots for a longer period because you might get a continuous EMG burst, as I said, and it suggests an ongoing root irritation. The conclusion. Intraoperative neurophysiology monitoring is a cornerstone of modern science surgery safety. Multimodalities approach enhances detection sensitivity and guides intraoperative correction. We cannot depend only on one modality like SSCP or MEP. Try and use multimodalities. Close coordination with the surgeon, anesthetist, and the neurophysiologist is the key to success of IONM. Proper protocol adherence significantly improves the neurological outcomes. Okay, thank you.
That was a wonderful, wonderful talk, Parichar ma'am. And Parichar ma'am is well known for her more than 3 decades of service to the field, and her significant contribution has made the lives of spine surgeons much, much easier. And we really like to thank you for your time and overall your service over the last 3 decades.
Thank you, Dr. Raj. Thank you for your kind words.
And next we have Ms. Nikita Singh, and she will give her wonderful talk, and she will discuss with us her experience with IONM and IONM errors. Ms. Nikita, you have.
Yeah, so just a sec. Yeah. Hello, everyone. So today I'm going to present on understanding and avoiding of IONM errors. So as we all know that IONM is an evolving safety tool, but errors in signal interpretation or handling can affect patient outcome. So my goal is to highlight common pitfalls and how to systematically identify and prevent them. So before we discuss the errors, let's quickly recall the basics of IONM. So here, if you see the diagram here, as per the homunculus, you can see a sensory motor cortex and the sensory cortex and the motor cortex. Sorry. So if you see here, we place the motor MEP electrodes in the motor cortex area. We stimulate from the motor cortex area and we record it from the respective muscles. Similarly, we stimulate from the peripheral nerve for SSCP and we record it from the somatosensory cortex area. Here you can see the T20 electrode montage system for MEP. The placement of the electrode of C3, C1, C2, and C4 are in the motor cortex area. So we stimulate from these particular area and we record it from the respective muscles. And for SSCP, we record it from C3-, C4-, FZ, and CZ. FZ acts as a reference point for upper SSCP as well as for the lower SSCP. Here, the first image shows the recording site for motor evoked potentials. Here, we can see, depending upon the surgery, we select the particular muscles and we record it from there. And in the other image, we can see the stimulation site for SSCP. We stimulate from the median nerve and posterior tibial nerve for upper and lower SSCP, respectively. So depending upon the surgical site, we select the muscles. So if it is a cervical surgery, we select the upper extremity muscles and few muscles in the lower extremity to check the conduction of the cord. But if it is a lower extremity, the surgery is in the lumbar region or the thoracic region, we consider one muscle above the surgical site and all the muscles below the surgical site. So let's get back to the introduction of IONMs. So basically, IONM, intraoperative neuromonitoring, provides real-time neural assessment. So error can arise from any technical, physiological, interpretive factors or any communication error. So our main goal here is to identify the common IONM errors, to understand the false positive and false negative responses, which leads to IONM error. Also, we'll discuss on the structure steps to verify the signal changes and to discover the preventive strategies to for error reduction. So the broader classification of IONM errors is classified into 4. The first one is a technical error. The technical error mainly consists of the electrical artifacts. The second is a physiological error that is mainly because of the anesthesia or any underlying pathological conditions. The interpretive error is due to due to neurotech or neurophysiologist misreading artifacts or missing true changes. And the last one is a communication error, which can be delayed or unclear reporting of the event. So let's start by discussing the first IONM error, that is the technical error. In technical error, the main focus is fault arises from the hardware, software, and the setup. So hardware is basically when your system is not working properly or is at fault. The software, when the software is not loading properly and it is showing you error. And the setup fault is when the technicians misplace the montages, and if the right lower limb or right electrodes are placed into the left and the left is placed into the right differential amplifier system. So the common causes of technical error is poor electrode contact, which causes a high impedance, then faulty cables or the connectors, incorrect polarity, and inadequate stimulus intensity or duration, and also an electrical noise or interference. How we can prevent these errors is by checking the impedance of the electrodes. It should be less than 5 kilo ohms. Secure the electrodes with a micropore or any adhesive tape so that it doesn't come out and it has no loose connections. Use differential amplifier and grounding pads correctly so that we can get a proper response over there, and maintain consistent setup throughout the surgery. The setup should not be moved here and there throughout the surgery. So these are the two responses of MEP. The first image shows an MEP without artifact and the second shows an MEP with an artifact. If you see in the first image, it is very clear that the responses from the muscles are very crisp and clear. In the second image, you can see a lot of artifacts along with the MEP responses. It is very difficult to identify which one is the MEP response and which one is the actually the artifacts. And this artifacts is caused due to electrical supply. So this is basically because of the poor grounding. So to avoid these artifacts, one has to rectify the grounding. And also there are few leakages from the other operating or electrical equipments which needs to be grounded. This is the second artifact, which is 50 to 60 hertz noise. Here you can see a very clear image of lower SSCP, and the other image, if you can see, there is a 50-60 hertz noise artifact. It is very difficult to identify which one is the response and which one is the noise. So to avoid these noises or to cut short these artifacts, one needs to apply filters so that it attenuates those noise and give you a crisp, clear response. So let's move on to the second error, which is a physiological error. Physiological error mainly deals with anesthesia and underlying pathological condition of the patients. It mimics the true injury and masks actual compromise. So by restoring the physiology, we often restore signal loss. Here are the key physiological influences. It mainly affects the anesthesia agent mainly affects the MEP and SSAP amplitude. It decreases the amplitude and increases the latency if the anesthesia or the drugs given is too much according to the requirement. So we prefer TIVA and along with the short-acting opioids. Then there should not be any neuromuscular blockade after induction because that will dampen our MEP and EMG responses. So to check whether the patient is under muscle relaxant or not, we need to check the TOF modality. And the TOF value should be more than 90%. If we check for the blood pressure, if the blood pressure goes low, the amplitude or the signals of the MEPs are lost. So the blood pressure should be more than 70 to 80 mmHg. Temperature should be maintained between 35.5 to 36.7 to get the proper response. Then oxygenation, then partial arterial carbon dioxide, everything should be maintained to get a proper response. Now, to prevent a physiological error, one needs to give, the patient should be under TIVA. It can be accommodated with propofol and short-acting opioid. The temperature should be maintained along with the perfusion. No long-acting muscle relaxant is recommended. Then monitor the baseline drift and latency trends. Then physiology first approach before escalating. So if there is any drop or any such responses wherein you have lost your MEPs overall, you should first escalate it with the anesthesia team, check with them whether if they have given any boluses or is there any drop in MAP or any changes in temperature or something, and then come to a conclusion later on. Clear communication among IONM and anesthesia team along with the surgery team is very vital. Now, these are the examples of physiological monitoring. The first image, you can see that there is a drop in MEP responses clearly due to drop in mean arterial pressure. But in the second image, once the mean arterial pressure is restored, you can see a very good MEP responses, which is as good as the baseline. So the very important question here we see is, can we monitor patients with grade 3 power? Okay, so in this condition, first I will discuss about the grades. The first grade is 5 to 4. In 5 to 4, we get a very excellent responses. We get a good cortical muscle connections, and we get MEPs very easily. Whereas in case of grade 3, it is possible to get an MEP, but it is variable. It depends on patient to patient. Again, the responses here are weaker and often high stimulation voltages is required. And in case of grade 2 or below, this year we often get an unreliable response, or most of the time it is absent because the corticospinal conduction is impaired and there is little to no muscle MEP responses. So your D-wave, EMG and SSCP plays an important vital role. Here you can use D-wave, SSCP and EMG for supporting with MEPs to get a proper responses. D-wave is not affected by the grades, though there are few axonal conduction changes, but then still you will get a D-wave in grade 2 or below responses. So these are the these are the flow chart which is required to avoid physiological errors. So in physiological error, first the patient needs to be analyzed by checking their grade power by MRC scale, then check the baseline and SSCP in supine position. Then once the patient is under TY, once the position has been done, during supine only, increase the train of pulses to get a good response from the patient. Then turn the patient to prone and keep your sides same. Change turn the position. Make the patient prone and check the MEPs again, and you'll get a good responses after that. So in such cases, signal interpretation accept low amplitude baseline. Loss during decompression, then you should inform the surgeon, and improvement is equal to the good prognosis. Complementary modalities which we need to use is D-wave, SSCP, free running EMG along with the MEPs. Now let's move on to the third error, which is interpretive error. So interpretive errors occurs mainly due to human error. So error arises when the neurophysiologist misreads waveform changes, or there is any delayed or incomplete recognition, artifact contamination mistaken for true neural activity, and context to technical and physiological of a change is not fully integrated before alerting or dismissing the event. So these are the responses of false positive and false negative. Due to misinterpretation of the responses, we tend to get a false positive and false negative responses. So misinterpreting artifacts as a true change. So incorrect recognition of physiological effect. For example, if the patient is under muscle relaxants, if the bolus is given to the patient, we tend to see that there are changes in the responses and we correlate it with the incident happened during the surgery. But actually it is due to the physiological error. So the communication should happen between the anesthesia team as well as the surgical team. So to prevent these errors, there is standardized interpretation criteria, and one should correlate this with the physiology, and there should always be a multimodal confirmation with a clear communication, and the team should be trained continuously, because there are certain things which is coming up every now and then. So the team should be continuously trained. Now, the basic communication. So the fourth error is the basic communication error. Now, it occurs when critical information is not transmitted and delayed, misunderstood, or misinterpreted between the teams. So the source of error could be a delayed reporting, ambiguous language, like a very vague language, vague terms are used during the surgery, incomplete handoff, as in if the team is switching, then the information is not shared during the shift or anesthesia change. Then the lack of closed loop information, as in if you inform the surgeon that there is any drop and there is no acknowledgement from the surgeon, then it is a lack of closed loop confirmation. Then the fear to escalate any errors. So the prevention of this is pre-operative team briefing. It is always good to have a team briefing before the surgery so that everyone is well aware of what is going to happen and what is the surgery going to happen and what are the steps each one of us is going to take. Then if there is an alarm criteria, if the amplitude has dropped by 50% and if the latency is increased by 10%, then it is an alarm criteria. You should inform the surgical team immediately. And there is a standardized reporting phrases which should be used during the surgery. There should not be any vague terms which can be used for communication. Then real-time documentation is very important to understand where exactly there was a loss, and there should be a closed loop communication. So whatever you are delivering or whatever you are talking during the surgery, it should be acknowledged by the person with whom you are addressing. So these are the case examples. The first one is when the MEPs was dropped by 90% on the lower limb, and technologist notes it, but it waits for the confirmation. But without informing surgeon, the surgeon advances the correction rod before being informed, and then the post-op, the patient has paralysis. So the error here was a delayed communication. Because of him not informing the surgeon, the patient woke up with a paralysis. The second case example is anesthesia, when the anesthesia team switches from TIVA to MAC 0.8 sevoflurane. In the mid case, the amplitude has dampened and suppressed, assuming it is a surgical cause. No immediate discussion was there between the neurophysiologist and the anesthesia team. Therefore, there was a cross-disciplinary communication gap, which could lead to miscommunication. So these are the basic IONM alerts criteria, or we can say how we can avoid IONM errors. So to first and the foremost thing is to verify the technical setup. Check the impedance, check the cable, secure the cable, see if there is any grounding artifacts or not. If there is any grounding artifacts, just go and rectify it. See if there is any electrical leakages, go and rectify it, ground that particular system. The second one is review anesthesia and physiology. Check patient underlying pathological condition, if patient is having prior pathological condition, and also check with the anesthesia team about the BP, temperature, agents which they are going to give, how they are going to maintain it, inform them about the bite block, and have a healthy discussion regarding the case. Then if there is any loss in the responses, re-stimulate to confirm the reproducibility. If there is any loss, recheck the MEPs again and again. And if you once it is done, confirm and then inform the surgeons. Pause if there is any surgical manipulation. If the responses has gone, you need to pause the surgical manipulation. Correlate it with the other modalities which you have currently. For example, SSCP, D-Wave, or any raw EMGs, and document all the actions which you are going to perform. So, to summarize, preventing IONM errors depends on three factors. One is stable physiology, second is accurate monitoring, and the third is seamless teamwork. So, thank you so much.
That was a beautiful talk, Ms. Nikita. A brilliant way to tell and recognize the errors and to avoid errors. We really thank you for your time during Diwali and sharing your knowledge. After this, we have our own Dr. Siddharth Shah, UK returned complex adult and pediatric deformity spine surgeon, and he will tell us how to communicate and how to have a good workflow with the IONM team. It's all up to you, all over to you, Dr. Siddharth Shah.
Yeah, can you see my presentation?
Yes, yes.
Good afternoon, everybody. Thanks, Raj and SpineTV team for this invite. It's a very niche topic, something which often gets overlooked at the bottom of a busy conference day. So this is a very good endeavor to bring this to light. Now, it's been a fantastic 3 talks. We've gone through the technicalities of it, the anatomy of it, how the IONM works. But the main question arises when every surgeon skips a beat or has a partial tachycardia is when the neuromonitoring team says we've got an alert. What do we do then? And that's where my talk and the following subsequent 2 talks are going to shed light on as to what to do and how to act and react to instance when you get alert for that matter. So it's a nice day. We are doing a nice adolescent scoliosis. Both surgeons are doing it in a good flow. Things are going well, and suddenly you hear your either Miss Parichar or Miss Nikita say in the background that, Doc, we got an alert. At that point, what we don't want is to be this guy, that we don't know. It should not be that we don't know what to do next, because that is where the problem begins. If we just take a step back, any scoliosis surgery or any deformity surgery or any complex surgery for that matter is like a well-oiled machine, and that machine is not, a surgeon is just one part of that whole machinery. There are variable factors there which all tend to sort of work in a very well symbiotic glue to be able to deliver that optimal surgical outcome for that patient. And it's this machinery which, when works efficiently in the theater, is what allows us to tackle any alert situation which may arise. Now, for us to ensure that the machinery works well, or where each aspect of the care works well, we need to know what those aspects are. And if we were to broadly shortlist, there are 4 for any deformity surgery, which is probably the most core of all the IONM work that we do. There are 4 aspects to the theater which are important. The technical aspect, the surgeon's aspect, the anesthetic aspect, and there's a small aspect of which I tend to call as the OT aspect. Now, I'll start with the OT first. Now, what do we mean by the OT? It's everything that is happening in the environment in the theater. For example, I like to do my surgeries, long surgeries, with music playing in the background. We have circulating staff going in and out. We have people who are taking a break, coming back. So as soon as there is an alert, first thing for us to do is for the surgeon to announce that we have had an alert, have that documented somewhere on a board, and make everybody aware that there are going to be a couple of steps which are now going to happen, where every different person is going to have to do something. So this announcement is one of the most important factors. It's not just for you to keep it to yourself. Every single person in the OT needs to know that we've had an alert and now we're going to do something differently. The surgery is now going to pause for a second, and there are different steps which are going to be taken. Now, those steps are going to be detailed down the line with Raj, who's going to go through the checklist. But we're going to run through how to communicate those steps. So first thing is, I would ask my circulating staff to stop the music. Have the anesthetist inform if there is the lead anesthetist outside the OT, bring them back in. It's always good to have 2 anesthetic team there. Have the neuromonitoring guys be on alert. Have the staff get ready warm saline in the corner. So there are small things which are going to be ready for us to action on as we go through the couple of steps. And each of them relies on you identifying it and communicating it. First, we'll come to the, let's say, anesthetic aspect. Now, as soon as you've had an alert, or throughout the surgery, as Nikita and Parichar madam has already come in detail, a big factor of what we monitor depends on how the anesthesia is. So first thing we go through is check on the anesthetic side. Speak to the anesthetist, see how the patient is. I turn around, I have a monitor which is always facing me, so I'm keeping a watch on the mean arterial pressure. But then we are looking at the factors. What's the blood loss? What's the pH of the patient? The anesthetist is going to run a new ABG at that point of time. what's the temperature of the patient at that point of time, because hypothermia can lead to us having an alteration in signals. Was there any recent inhalation or IV agent given? All of these aspects are the ones which are usually checked the first, because these are the very sensitive points which can easily be corrected, especially your blood pressure, the temperature, which needs to be looked at. So the first thing is, have the anesthetist come up, do a check of all the parameters that the patient is going through, feed them back to you and the technical team at the back. Both of us should be happy that if everything is there at the anesthetic end, the map is optimized, the temperature is good, the patient is in sort of a normal hematocrit, and all other anesthetic aspects are fine, then we move on to asking the next aspect, which is the technical aspect. Now, from a technical perspective, Nikita is beautifully given a workflow of what things we would check. But for us, even before we come to an alert, your communication with the technical team is so important, because it is not just about the alert happening or not. It's about when that alert happened is where the issue lies. Just a simple example, for me, because we work with the same team at every case, my technical team knows that after I put every screw, they need to check an MEP. The rationale being, I need to know which screw caused that decline in the MEP, if it did. So the usual workflow is that we do a baseline reading with the patient supine. We do one with the patient prone. If you're going to apply hilofemoral traction, then we do one after traction goes on in prone. Then we do one before we start the exposure, one before we start putting the first metalwork in, and then there is a trigger MEP done at every pedicle screw. That helps us stratify and document where the issue happened, because picking up the issue is one thing, but picking up the issue in the right time is going to make a lot of a difference to how much of it you can correct and reverse. So doing these small things does help. The second aspect is, once the screws are in, you would want to check if the screws have a breach or not. For that, there are two schools of thought. I tend to check all my pedicle probe screws at the end, one altogether, but some surgeons tend to do it again after each screw is placed. That depends on the surgeon's preference. As long as the MEP is okay after every screw, you heard your neuromonitoring team say that we've got a good response after each screw, your communication channel is smooth and it maintains, then you move on to the next screw. We finish the left-sided screws, we document the end of instrumentation on the left, we move on, we document end of instrumentation on the right. If everything going well, you contour your rods, you put those rods in, before you put them in, before you start doing your rod rotation, derotation, segmental correction, apical translation, you declare that we are now beginning the correction. The anesthetist makes sure that the blood pressure is pumped up a bit, your map is good. The technical team knows that we are in a sensitive zone now. So to us to expect any changes in the MEP that may come, or any neuromonitoring modality. So this communication ensures that everybody is alert. It's more about being alert in that time frame rather than being there throughout the surgery. Once we are doing the correction, we document that the correction is ended, all monitoring is fine. That's where the whole process stops, in a sense that we are now at a stage where there is no more variable factor from a surgical perspective. But of course, the anesthetic bait and everything still continues. But this tends to be something which you are in close communication with the technical team as to what step of surgery you are performing when the technical team needs to do a particular set of steps. Of course, surgeon aspect lies at the core of the instrumentation work. When you're putting your screws in, when you're doing your corrections, all of this needs to be aware by yourself. Of course, your skill would be vitally important, and we underlie that fact that when we're doing, as a deformity surgeon, you would have that expertise, you would have that checklist. I have a practice where the checklist which Raj would speak of, it's a Vitalis checklist. It's there as a printout in the theater, on the side, on a wall, for everybody in the team to refer to, just in case there is an alert. You have a frame of reference as to what you need to look at and what you need to check how. It's only when all these four aspects work together is when the workflow in the OT, the communication in the OT runs smooth, is when your outcome from the surgery is going to be smooth. Your outcome for your own cardiac health is going to be good, because at the end of the day, it's not just the patient who goes through the surgery, it's every person present in the OT who goes through the same stress of the surgery. And as long as each communicates with each other, the load distributes to all. It's a well-oiled machine which gives you the most optimum outcome for your patients. Thank you.
Thank you, Dr. Siddharth Shah. So that's really, really wonderful talk. Like Dr. Shah was discussing communication and workflow. All these small things are very important. One of my mentors used to say, the God is in small details and small things that eventually improves and gives the best outcome for you. Now, up next, we have one of the dynamic surgeons, one of the senior consultant spine surgeons from Dhaka, Bangladesh, Dr. O Z M Dastagir, and he will tell us the review literature, the current concepts which we are using in IONM. It's all over to you, Dr. Dastagir. As we are running out of time and a little short, I request you to run a little quicker. You're muted, Dr. Dastagir. Dr. Dastagir, you're muted. You need to unmute yourself.
Good afternoon, everyone. So I've
Good
come.
afternoon.
Hello. Can you hear me?
Yes, we can hear you.
So as we have there is a nice discussion regarding all issues are tasked. So it is a intraoperative neuromonitoring. It is not just a tool. It is a system of multidisciplinary vigilance, guided response, and it's a continuous learning, and it's a teamwork. So I have gone through some latest article. So I am sharing with you my views after reading this article. So in this article, in Phalanx, in 2024, their recommendation is to multimodal for high-risk cases, and after define the standardized alert response pathway, and it emphasizes on the whole team and anesthesia coordination and high specificity in somatosensory evoke potential and high sensitivity of the motor evoke potential. So in pediatric deformity surgery, Lewis in 2019 paper, it is a retrospective study. There is a there is a 97 cases. It is in this retrospective study, and their key findings, it's 27.8% incidence of intraoperative neuromonitoring alerts, and it is divided into alerts are divided into two types, that is perfusion based and direct trauma based. So there is a classified bilateral versus unilateral. So core message from this literature, that is the dividing alerts by pathophysiology, that is perfusion versus trauma, enables targeted response and safer deformity correction. So if there is a perfusion, there is a raised mean arterial pressure, then do transfuse and release rods. And if there is any trauma, then stop the maneuver and inspect and reverse. And if there is a no post-operative deficit, when algorithm followed, and it validates the practical and stepwise interoperative response.
I will just add few quick points on this
And
article.
in
Dr. Dastagir, can you hear me?
2025, yes.
Yeah, we'll
Can you
just
hear me?
add few points on the Dr. Lewis paper. Like
Yes.
been fortunate to
OS.
work with Dr. Lewis and with Dr. Nielsen. If you could
Yes.
go back to previous slide.
Okay.
Yeah.
Yes.
So
Okay.
this
Okay, you can discuss.
paper is very classic paper.
Yes.
This paper is very classical paper, and it
Yes.
tries to give the algorithm and tries to discuss what could be the cause of the alert, and it divides into two, whether it's perfusion, Perfusion
Perfusion,
means
yes.
anterior spinal artery injury because of the stretch or because of the deformity correction, which leads to the kind of ischemia of the spinal cord, leading to the bilateral or global intraoperative neuromonitoring change, leading to the weakness or symptoms because of that. And other is because of the trauma or the mechanical pressure. Either there is a impeding or impinging screw, or any of your laminectomy defect while operating, you injure the cord. So they divide into perfusion injury versus mechanical injury. The mechanical injury, when you found it, you can correct it immediately. Either you remove the screw which is impinging on the cord on the nerve, or if there is a laminectomy or if there is a Ponte's osteotomy you've been doing and correcting, and that's been the cause for the unilateral issue or IONM change, you can correct that at the same time. And the bilateral perfusion injury is because of the, as I said, there is coronary artery syndrome, or the we call angina of the heart. It's the same thing for the angina of the spinal cord. And that's because of the elasticity of the spinal cord, it's much less. You can't stretch the leventhal discuss. The stretching strength of the cord is just 0.25 as compared to any other muscle. So this stretch can lead to the anterior spinal artery injury, leading to the cord ischemia. How to reverse that? First, you can raise the mean arterial pressure by going higher, 85 to 90. You can correct the hemoglobin more than 100 or 10 hemoglobin. You can correct the lactic acidosis. We'll discuss these further things in the checklist, but this is one of the important articles which tries to give guidelines whether the change happened because of the perfusion or change happened because of the trauma. We can go ahead, Dr. Dastagir. Thank you very much for
Yes,
bringing this
thank you
article.
very much. And in 2025, there is a Nielsen, the adult deformity review. So they discuss about the high deformity, the cases, that is, they discusses about the high risk patient, and there is a three column osteotomy and blood loss to increase. In these cases, they suggested the intraoperative neuromonitoring, and it is also promotes checklist-based intraoperative neuromonitoring management. So if there is a recommendation that if there is a perfusion loss, then correct the mean arterial pressure, oxygen temperature. And if it is due to trauma, then reverse the step and decompress and recheck the signal. And checklist also improves the consistency and safety. In the finally, it's a very recent article, Wieland et al. That is 2025. It directs the feature of the intraoperative neuromonitoring. So it describes the using intraoperative neuromonitoring in spine surgery. AI can improve the alert detection and accuracy. So you can see it in future. And it is also a team performance and data metrics, and advocates the large data sets for validation and shift the focus to the therapeutic value to alerts. And so it's a foundation paper in future. So adoption of this structured intraoperative neuromonitoring checklist and spine praxis pathway minimizes the neurologic injury and improves the team readiness in complex spinal surgery. So from this last four papers, from reactive responses in Lewis paper and standardized global protocols in Fenning's paper 2024, and the adult deformity checklist and prevention framework that is Nielsen describes in 2025 papers. And then lastly, in the papers, the Wieland in NAS journal in the future direction of the intraoperative neuromonitoring. Thank you for patient sharing.
Thank you, Dr. Dastagir. That's a beautiful talk. Really impressive. All the recent literature, which meaningful conclusions you gave us, and that I feel will help all the spine surgeons across the globe in their practice. So we are coming into the last segment where we want to discuss to this checklist, where every spine surgeon, deformity surgeon should know about it and should act on it. Before that, I will discuss the table. So the consensus table, most of it has been covered. but we'll discuss the 5 important points from the with Michael Vitale, Lenky, and Steve Lewis article. So the table gives most important 5 points. It talks about it's a team approach. The surgeon anesthetist, as Dr. Siddharth Shah and everyone was communicating, neuromonitoring. SSCP should be monitored in all cases. There are some patients with neuromuscular scoliosis when we don't have the MEPs, but the SSCP act as the standard or the cohort or baseline for us. So SSCP should be monitored in all spine deformity cases, even in neuromuscular cases where the GMF is 5. This is helpful. Transcranial motor evoked potential or descending neurogenic evoked potential should be used in all spine deformity cases. We've been currently doing the AO spine review for the IONM. The data is still in early phase. More than thousands of responses have been received. Still, about 10 to 15% of the deformity surgeons think that intraoperative neuromonitoring is not must. So we want to give a strong message and clear message that for the deformity cases, there is no option of neuromonitoring, that the neuromonitoring, intraoperative neuromonitoring is must and very important for the safety of spine surgery. That being said, it's always discussed in all the conferences that the greatest invention in spine surgery has been to improve the safety is intraoperative neuromonitoring. Apart from this, the 2 points are more than 50% degradation is considered the significant or alarm criteria or warning criteria. If we get more than 50% degradation or more than 10% latency, it's considered as an alarm criteria. At the end, wake-up test or Stagnera wake-up test should be used when there is a consistent or persistent signal loss, and we should wake up the patient during the procedure, check the neurology, and then decide to go ahead with the surgery or not. With that, we'll discuss the most important slide in the deformity surgery, that the checklist. First, as Dr. Shah and everyone was discussing, you need to gain control of the room. You need to stop the music. You need to stop the discussions between the circulatory nurse or other nurse or everything. You need complete silence. You need to have control of the theater. You need to get the senior anesthesiologist who's in charge of the case. We need to get the senior neurotech, neurophysiologist, and the experienced staff. Then you need to review the case once they have alerted. You need to check, call the X-ray or inform the CT scan that we have signal change. We might need to review our screws. We either with the Shyam or intraoperative CT scan like OARM or any intraoperative CT scan, so that the time from the event to the checking of the hardware is less. That's the gaining control of the room, followed by the anesthetic or the systemic. The change, as we were discussing, could be because of the ischemic injury or because of the low MAP pressures, the mean arterial pressure. So you need to run the MAP pressure high, more than 85 to 95. Some suggest 100, but as per the patient's baseline, you need to run the MAPs high, more than 85 to 95 mmHg. The hematocrit, if the oxygen carrying capacity of the blood, that's hemoglobin is less, again, there will be ischemia of the cord, and that can also give rise to the intraoperative neuromonitoring change. So you need to increase your hemoglobins more than 10 hemoglobin or 100. You need to check the blood gases, check and optimize your blood pH as well as the PCO2, the lactic acidosis. All these things you need to control. That also significantly affect your intraoperative neuromonitoring signals. You need to, because of the theater, and we need the cold temperature in the theater, patients sometimes go in hypothermia. You need to kind of reverse the hypothermia and give the patient the normothermia with the warmers and all the warm blankets, make the patient to the normal temperature. Also discuss with the patient that before the surgery, that in between the surgery, we might do something called wake-up test and train the patients before the surgery itself. The anesthetist will be giving you a call, and when she gives a call, you might not understand a bit, but all you need to do is move your legs. And that's kind of helps during the surgery, that when the anesthetist or the surgeon gives the wake-up call and tells the patient to move your legs, and the patient understands and moves the legs. That's called the wake-up test. And that's very important from the intra point of view, that patient understands your suggestions, guidelines, and moves the legs and in cohesion with the team. Then the technical issues, the neurophysiological issues, we need to discuss the status of the anesthetic agent. Sometimes, as we discussed, there could be inhalation agent given, or there could be some skeletal muscle relaxant given. As we get the baseline, we give skeletal muscle relaxant during the exposure, so that the exposure is a little easier. So you need to check if the muscle relaxant still is on, or if the inhalation agent is being given. Followed by, you need to check if there is a neuromuscular blockade or degree of paralysis has been discussed. Now, you need to check all the electrodes and the connections, if they are connected very well, or if there is a discrepancy. Most importantly, check the pattern. If you have irregular loss or bilateral loss, if you have just if you are working below the cord, if there's nerve damage. So all you need, MEP changes, SSVP changes, all changes you need to check. You need to define what kind of changes, whether you're getting the Brown-Sequard syndrome, or you're getting the posterior column syndrome or anterior column syndrome, or you need to check with the help of the MEPs as well as the SSCPs. You need to check the neck and the limbs if they are still in 90-90 position, because stretching of the nerves in the position of the shoulders as well as the hips and the knees can sometimes give the loss, and that could be also important to look after. Then the last and important, you need to check the surgical manuals. If we are given the fraction, like sometimes in pediatric adult cases, we put head traction and leg traction and weights. You need to remove that weight. That removes the stretch on the cord. That also helps to reducing the signals or reversing the signals. If you have put the rod and have distracted the concave side significantly, and that is causing the change, then we need to remove the cord or decrease the stretch or the concavity stretch you have done or distraction you have done. That also helps to reduce the anterior spinal artery spasm and reverse the signals. If the signals, even after reducing the distraction, are not moving, just remove the rods and check the screws, as Dr. Shah was explaining. Check the screws. I prefer to check my screws after putting every screw, that because all these signals are not exact real time. There is always a lag of 15 to 20 minutes. So whatever maneuver you're doing now, and will give the signal 20 minutes later. So when you get the signal, reverse and reanalyze whatever you have been doing, and check all the steps and reverse the steps over the 20 minutes you have been doing. Eventually, evaluate all your osteotomies, evaluate pontes and laminotomous sites. If they are causing compression on the cord, try to decompress more, keep the spinal cord free, check your fluoroscopy and C-arm and O-arm, check all the screws. And still, if the signal is still present, remove the cord, maybe reassess the situation, close and come at later stage. So all these things are very important, and there are other points they have been discussed, that revisit anesthetic and systematic considerations. The wake-up test is important. Always consult with the colleague that during the surgery, there is no shame or there is no ego. If you have signals for the importance of the patients, call your senior colleagues and discuss that this is the signals we are getting, what should we do further, and they will definitely guide you what should be done with their experience. And also the checklist is there to help you. Continue surgical procedure versus staging the procedure. That's again another important factor. If you're getting the loss, IONM loss, and even after following the checklist and it's not improving, I personally feel to stage the procedure. I close the wound, go and discuss with the patient and the relatives that we have not went ahead with the procedure, that we have lost the signals. But some surgeons feel confident that there is no intraoperative screw impingement or the cord impingement, and the patient will not have any adverse effect. They go ahead with the surgery. It all comes with the experience. And individual institutional protocols. And there is a steroid protocol also, methylprednisolone 30 milligram per kg in first hour, followed by 5.4 milligram per kg per hour for next 23 hours. That eventually reduces the swelling, the edema on the spinal cord, and that kind of helps to reduce the inflammation and maybe get back a little bit paresis the patient has. With that, we are open for the discussion. If anyone has questions regarding all the topic, Dr. Taarini, Ms. Parichar, Ms. Nikita, Dr. Dastagir, or Siddharth, we are open for discussion. We have like 3-4 minutes to discuss. We can take 1 or 2 questions. Or Ms. Anchal, you have any questions?
No. Thank you.
Okay, cool. Dr. Taarini,
Dr.
any questions?
Dr. Raj, can I ask a question?
Yes.
Have you all
Yes.
seen that steroids really helps and warm saline really helps in your surgeries when there is a drop and when we raise an alarm and when we give warm saline wash and steroids, does it help? Have you all seen it in your cases?
Yeah, so again, this is a highly debatable topic across the globe. First,
Yes.
because the guidelines came and it said it helps. Followed by there is NATS guideline that it might increase the comorbidities in the patients with the heavy comorbidities, that it might be detrimental. But again, the research by NAS guidelines as saying that it might be helpful. So the literature is still in a dilemma and still in discussion, that in some patients it might be helpful and in some patients it might not be. But personally, more at various centers I worked either in Canada or Australia, they kind of feel that sometimes if the patient does not have much comorbidities, patient is all healthy, then steroid might be helpful. But the patient is having severe comorbidities, then they try to avoid it, because in those cases the risk benefit ratio is more towards the risk. So this is the current literature, and this has been followed in various institutional guidelines. We have Dr. Siddharth Shah. He can give his thoughts on this.
Benefit of that. Okay, thank you.
Personal pragmatic level, I'd say I will still do it in the absence of any conclusive evidence, for the lack of not having anything else which we could do. So the devil is in just the way it acts. We give the warm saline because we hope that the heat would cause vasodilation and improve the blood circulation to the cord. And the steroid is given not as an acute anti-inflammatory to the cord, but is to cut short that inflammatory cascade that starts from the time where there is a neurological injury, to prevent the neuroglia from sort of what we say necrosing and going on to form a neurological scar. So the principle of using these is, at least for me personally, I would still use it in every single case. There is a warm saline always ready, because short of those two is just like, when we used to have the discussion about steroids in spinal cord injury, traumatic spinal cord injury, people still do it because we don't have any other ways and means. I would still do it. And as Raj said, unless there is an absolute significant morbid status, the risks are far less as compared to the potential benefits that you may have from using these modalities to prevent a potential neurological insult.
Yeah, so we also do use. Most of the time, when I enter, I tell the nurse, circulating nurse, keep warm saline ready.
Yeah.
So it is a good thing. We should continue.
Warm saline also works. I mean, in the smaller ways, it actually helps in also.
Yes, we have seen, Dr. Siddharth, I think.
Of the child.
Yes.
So when you give warm from the top and along with the underbody warmer, the heat from both the parts does warm the core up also.
Cord,
the heat for the core is also to improve the hypothermia.
Okay.
Yeah.
Okay.
And there is still some discussion about the hyperbaric oxygen post-op for a few days. That kind of eventually improves the oxygenation of the cord. But still in the research phase, no conclusive significant evidence that the hyperbaric oxygen improves the spinal cord perfusion. But these are the different modalities used across the globe. I think with that, we would like to conclude. Thank you very much. Thank you, Dr. Taarini, Johri. Fantastic talk. Thank you, Ms. Parichar, phenomenal
Thank you.
talk.
Thank you.
Your experience of 30 years been seen over your
Thank
talk.
you
Thank you,
so much.
Nikita. Brilliant talk. Siddharth, Shah, the communication talk and workflow was phenomenal. Dastagir, you reviewed all the literatures, all the recent literature so well. And thanks to me for getting all this brilliant cast.
Yes,
With
thank
that,
you,
we
Dr.
stop
Raj,
here.
for giving
Thank
this
you very much.
opportunity.
Dr. Raj,
And
thank
don't
you.
leave. I request
Yeah.
not to leave because we are doing this 30 seconds reel.
Okay, sure.
Okay.
Okay.
So, Rishi,
Yes, sir.
hello. Yeah, I'd like to thank you, everyone from OrthoTV SpineTV team, Rishi, Maharishi, Poonam ma'am, Ashok, Shyam sir, Dr. Neeraj Bijlani, and Dr. Nitin Saroj, and everyone for giving this opportunity and helping us to share this talk during the Diwali time. Thank you very much.
Thank you very much, sir.